We are going live. Just going to give everyone a chance to jump on. Okay, thanks everyone for joining us this evening. We're really looking forward to having another really informative webinar. Obviously, with this month, celebrating numerous cancers, including blood cancers and childhood cancers, we thought it would be pertinent to obviously take an opportunity to not only raise awareness of blood cancers and disorders, but also just to get some insights as to what it's like living with these conditions, as well as what are the signs and symptoms, etc. And really just to get a better understanding of these cancers that really have massive impact in the lives of those that are impacted. So we'll be joined by 3 speakers this evening. The first being Dr. Yasmin Goga, who is a hematologist, a pediatric hematologist at Igazi Albert Lutuli Central Hospital. And then we'll be followed by Trevor Steyn, who is the chairperson of CMLSA. And last but not least, we'll have Dr. Cole Cameron, who's also the CEO of the Igazi Foundation.
Not a doctor, not a doctor.
Sorry, Cole, I'm having one of those days where doing 17 different things and hoping that this has actually gone live on Facebook. So without any further ado, I think I'm just checking. We have got quite a few people that have joined us online already. And so, yeah, I think if you can, we'll be ready to start. So I'm going to start off by introducing Dr. Goga. If you can just give me 1 second, there we go. All right, so as stated, Dr. Goga is a pediatric clinical hematologist who studied at the University of Witwatersrand and then completed her PEDS at CMSA. Obviously has a very keen interest in clinical hematology, particularly in PEDS, and anybody who's been impacted by a childhood cancer knows a pediatric hematologist quite difficult to find, and we're very, very grateful for the ones that are around. She has worked in the Pediatric Hematology and Oncology unit at Igazi Albert Lutuli Central Hospital, as well as the Haemophilia Comprehensive Care Centre at King Edward Hospital, which is in Durban in South Africa since 2003. And her areas of interest include leukemias and lymphomas, thalassemia and haemophilia. She's been involved in the South African thalassemia guidelines, as well as the haemophilia registry and low-dose prophylaxis protocol. And her talk this evening is childhood cancer, blood cancers, and managing patients in 2020. And as we know, 2020 has been fun. So if I can hand over to you.
Good evening, everybody. Kelly, I'm just going to try and share my screen. Okay, just let me know if that is showing through clearly.
It is, if you can, there we go, it is, yeah.
Okay, so I've got a very big topic to cover today, which is quite a challenge, but I'm going to do what I can in the time that I have. And September is Childhood Cancer Awareness Month, which is why I think rare diseases have put us at the forefront. So I'm going to share with you a journey of one of my patients very briefly. AD is a 7-year-old, and he presented with bleeding, fever, and tiredness. After numerous visits to the local clinic, he eventually ended up with a private GP who found that he was pale, he had enlarged glands, and a palpable liver and spleen. So he was then referred to the local hospital, where initial blood tests showed that all his blood counts were low. The blood was then sent for review to a tertiary hospital, where they confirmed it as being an acute leukemia, and he was then finally transferred to a PEDS hemonc unit. So this cartoon just shows some of the main features that children with leukemia will present with, and that's because whatever's supposed to be produced in their blood, the red cells, the white cells, and the platelets are usually all fairly low. So one would present with tiredness, headaches, they may have bruising and bleeding, swelling of the abdomen might be noted, and they often have bone or joint pain. Okay, so what happened to AD? He arrived at hospital late that night. His mother was with him. She had to make her way from another town where she was working. So one needs to also realize the trauma that this family faces up front. I've put in some pictures of what patients will undergo to make a diagnosis of leukemia. And there's a number of tests that we need to do. These include a simple full blood count, which is drawn peripherally. Although I say simple, it minimizes actually the trauma that goes with it. Any of us as adults, and worse, more so as children, putting a needle in is equal to pain. We can try and minimize that, but there is still pain. And I think that needs to be recognized, that what we think is the most simple of investigations doesn't come without anything attached to it. So other tests that AD would have had would include a bone marrow aspiration and biopsy. And in older children, this is typically done on the posterior iliac spine. Some units have access to theater, and this would be done under general anesthesia. But for most of the units in state, we usually end up having to sedate our children in the ward and then try to do this, bearing in mind we need to minimize their pain. At the same time, we know that leukemia can spread to the brain. So we usually take a sample of fluid via a procedure called a lumbar puncture, and we do this usually at the same time. So AD was then diagnosed with what is regarded as a high-risk leukemia, and he was started on more intensive treatment together with a drug called imatinib. What happened to AD? Well, he had a fairly good team of doctors around him. We had a good relationship with the mom. The social worker was with him to provide counseling to the mom, and all went fairly well for the first few years. He had a good response to his chemotherapy. He actually completed 4 years of treatment in May this year amidst COVID. We repeated his bone marrow test, and everything came back showing that he was in remission. So at this point in time, this is his journey, 4 years of treatment later, many blood tests, several bone marrows, several lumbar punctures, and it all looks good. Except we fast forward a few months later, and he's now presented to his base hospital with a high white cell count of 90. We bring him back into the unit and we confirm a relapse. There's now possibly an additional clone that wasn't there before, and we now start to look at what treatment options are available. So we have a relapse therapy protocol, but unfortunately some drugs are not available. Ideally, one would need a drug called dasatinib, and beyond that, we would also want to transplant him. And that's where the problems begin, because he is an only child. He does have some matches on the bone marrow registry, but these matches are overseas. He's not on medical aid, and at the moment his options are limited as he's managed in the state sector. So this is the cancer journey, and it's really a very windy, tortuous path. It is not a straight line. What begins with the suspicion of symptoms, various tests, more tests, treatment, rehab, and we find ourselves at the point where he is right now, where we hope the vast majority of our patients stay in remission, but some of them do present with relapse, and that requires more treatment, and hopefully we will get him into remission. So it is a long and arduous journey. So to just put it in context, how common is childhood leukemia? Why do we have an entire month dedicated to this? So pediatric tumors are rare overall compared to adult tumors. And if you look at leukemia and lymphoma itself, these account for about 1/3 of the pediatric tumors, right? The next big group is the brain tumors, which in South Africa are generally underdiagnosed. And this is followed by what we term the solid tumors, which make up the rest. So children are constant change. That is all I can say. And the same goes for the malignancies that sit with them through the various phases. So in the newborn, for example, you can see we speak of congenital leukemia. We even speak of metastases or spread of cancers from mom to child. There's a different group of malignancies that become more apparent in infancy and early childhood, and then again in adolescence. But ALLs and AMLs, the two types of acute leukemia that we get in childhood, generally tend to present in early childhood through to adolescence. Okay, so one of the things that parents find hard to understand about leukemia, especially if there's no significant hepatosplenomegaly, there's no large glands, is to visualize this malignancy. Okay, where is it sitting? So if you look at childhood leukemia, there's two big groups, which is acute and chronic. And under the acute lymphomas, we have acute lymphoblastic leukemia. And there we have two varieties, B cell and T cell. And then the other big group is the acute myeloid leukemia. And this just gives you some kind of example of what these various cells look like. CLL is mainly an adult leukemia, and we don't actually see much of those. So ideally, what I would like at some stage is for us to have a model like this, which depicts half of the bone having normal cells, and we could have some happy neutrophils, lots of red cells, yellow ones or yellow beads for platelets, and a happy, healthy bone marrow. And I'd then like to have a model made which shows in the other half of the bone exactly what happens with cancer, where the number of red beads or red cells would be much lower, very few platelets, and many larger blue beads, which would signify the malignant cells. Okay, so that's looking at what happens in the bone marrow, but how quickly does this process occur? Doctors, when they are young, are sometimes skeptical, and sometimes they don't believe parents, and this is the reality. So when a child comes in with a white count of 300 and the history is 3 weeks, you might find a young doctor saying, I don't believe you, okay? But this is what they need to understand, is that it depends on the rate of growth of the cells. And what happens in some children may take a bit longer, it may take a few months, 2 to 3 months, and in some children it may be a very, very rapid process. But you get clonal expansion of the new cell line, which is the malignant line, and that replaces the normal hemopoietic tissue. So it's fortuitous that the treatment of childhood leukemia, and particularly ALL, reached its 50-year journey in the UK, in the States, in 2013. So that's 7 years ago. And these two articles basically summarize the key events. Leukemia, particularly ALL in childhood, has been the model for which treatment for many other malignancies have been based on, and this definitely led the way. So if we look specifically at ALL, or lymphoblastic leukemia, we usually try to divide this into high risk or standard risk groups. And I don't want to get into the detail of it all, but we look at things like age, the type of the cell, whether they're spread to the brain, whether there was a good response to treatment right at the beginning. And in doing so, we look at whether the patient is in what we call remission at the end of induction, which means less than 5% blasts in the bone marrow, Further, more specific tests called MRD or minimal residual disease. There are two key points at the end of induction and consolidation, which will tell us that this patient is responding well. The other thing that we look at is cytogenetics. And I usually, in some patients, it's more difficult to conceptualize what is a gene. Interestingly enough, in Zulu, there is no word to describe what is a gene. So you have to find other ways of trying to explain it. So one of my ways is actually to say, these are the flags that the cells carry. So are they carrying a flag that's a good flag or one that's a more difficult one to treat? So why is it important to prognosticate and divide this into groups? And this is simply because we want to make sure that we give maximum treatment that a patient will tolerate only where it's needed. So if you have a high-risk leukemia, an intensive, aggressive leukemia, then you need much stronger chemotherapy to try and kill those cells. You don't want to use more chemotherapy than you need. So chemotherapy in itself comes with side effects. When you look at the treatment of pediatric leukemia, what you see here is basically the results of studies done by the COG group in the States. And this treatment goes back many, many years. So each of these lines represents a different study cohort, the first one being done in 1962. And you can see at that point how dismal the survival was. So we were sitting with survival of under 10% at that point. Whereas if you look at what's happened with leukemia, ALL specifically, you now have a 90 to 95% chance of survival at 5 years in developed countries. And that is actually amazing. Okay, so I'm again not going to go through all of this, but there's 2 or 3 slides which just highlight what happens when you take each of these cancers in and look at how the therapy evolves. So right at the beginning in 1948, there were transient remissions which were induced by aminopterin, right? 1967, they started with combination chemotherapy. 1981, they found that if you intensify therapy, it improves outcome. At this point, most patients were receiving treatment for cranial prophylaxis because we know that the leukemia cells like to hide in the brain. And if we don't use specific treatment for that, then when the cancer comes back, because it hasn't been killed, because medication doesn't go across sufficiently, something specific to address the CNS therapy needed to be done. And initially, this used to be done with radiotherapy. However, radiotherapy means basically applying radioactive waves to the entire brain, and that had a lot of fallout with it, both in terms of second malignancies, cognitive problems. If you did it in a younger child, you might have ended up with microcephaly. So as far back as 1982, they began replacing cranial irradiation in some patients with intrathecal therapy, so actually delivering chemotherapy into that space where the fluid is sitting. So we've gone through further changes, and what's happened now is increasingly this is looking at personalized medication. So we are now looking at what is your gene like? How does this medication react to your gene? Is it the right medication for your genetic makeup? Do we need to make adjustments to the grouping, to the dosing of the medication? Okay, we will be having Theo speak to us on imatinib, and that's also now got a role to play in acute Philadelphia chromosome positive ALL. So that is where we are. And the sad reality is, in the time that I've been doing hematology, which is now almost 18 years, we have had possibly only 2 new drugs in state. Yet this table, and it's a busy table, but it shows you the number of drugs that are now available, but they're not available in South Africa, and they're not available in the developed world. But these are drugs that are now going to be critical to improve survival and to get our patients up to that survival rate. On the other side of the coin, we have acute myeloid leukemia. And this is a much more mixed bag. It's a very, what we term a heterogeneous disease. It's far more aggressive, and it requires then more intensive in-hospital treatment. Now, in developed countries where you have access to all of those newer drugs that I showed you earlier, and you have access to transplantation, the cure rates are a lot better. Not as good as with ALL, but better. In South Africa, we do not see cure rates like this. And our cure rates, because we don't have access to transplantation, both for the reasons of not having access to overseas transplant and not finding donors, our cure rates are actually dismally low for AML. The prognosis, therefore, is unfavorable, and we have a high relapse rate of about 30%. What is being brought into the South African market, and we are hoping that we can get this into the state sector as well, are drugs that specifically target FLT3 and the KIT mutations. So this is a question that parents often ask: what causes cancer in children? And the answer is, for most of the children, we don't know. It's idiopathic. But there may be a background of pre-existing immune deficiencies, exposure to radiation, benzene, toxin exposure. Some children have had previous chemotherapy, some viruses that predispose you, what we term epigenetic changes. And then we still wait to see what's the role of electromagnetic radiation and the role of genetically modified foods. So the question that we get asked very frequently is about diet. Doctor, what should I give my child? Okay. And it's definitely not all the stuff on the left. What we do know about diet and malignancy is that if you have weight loss and malnutrition, that's associated with a poorer prognosis in many malignancies, and nutritional support shows improvement in outcomes in some, but not all studies. Obesity is not only a global epidemic, it is also now a South African epidemic. And one needs to just look around and see what's happening to the children and the adults around us. However, if you have chronically reduced caloric and vitamin intake, this delays the recovery of healthy tissue from chemo and radiotherapy. And it also has effects on the immune system. There's now a huge body of literature looking at the positive correlation between obesity and poorer prognosis in malignancy. Another thing I just want to briefly touch on is pain. I started off by saying that I one day had to have many blood tests done. And this is my child in the middle of the world when he was just about to start school. He's now single, alone, in a hospital, in a cold room, having things done. What we do need to do is be aware of pain, that it's not just body, but it's mind, it's anxiety, anger, frustration, it's missing normal development. So it's not just physical, but there's physical, emotional, psychological, and spiritual pain that is experienced. And we need to look more deeply at our services and ask ourselves, what more can be done? At this point, the only treatment that we have for pain in state hospitals for children is paracetamol, Valigan, Valeron, and morphine. There's no in between. We don't have the sustained release morphine tablets. We don't have suitable preparations. So in terms of pharmacological, we have a lot that needs to be done. Things like massage and physiotherapy, activity, movement, things like that work in terms of the psychological, the relaxation, the deep breathing, the more intensive psychological support. All of these have a lot that need to be improved. And the last one here, effective parental responses. How do we get the parent and the child to work together as a team? So I mentioned that AD needed, ideally, in terms of his relapse, a transplant. And many parents don't exactly know what this entails. Many donors are very worried and weary, as they feel that they will probably need to have needles stuck into their hip bones and the stem cells removed. These days, it's very different. So we put in a central line on a patient. Patient is put onto an apheresis machine, which is similar to a dialysis machine. And for a few days before that, the donor will be receiving Neupogen or filgrastim injections, which stimulate the stem cells to be increased in number. So it's a parallel process. On the one hand, the donor is being prepped, and on the other hand, the patient is being prepped. So here we see the donor on her apheresis machine, and they are collecting the stem cells. And at the same time, the patient has been receiving chemotherapy, because to put it simply, we need to literally demolish what's happening in his bone marrow so we can build a new home. Actual infusion of stem cells is simple. It's in a bag through a central line, and the stem cells are beautiful in that they have a homing mechanism and they know exactly that they must go to the bone marrow. What stops us in South Africa? So we have a very well-run South African bone marrow registry. Unfortunately, government funding is not significant when you come to look at the registry, and the donor base has largely been driven by individuals who feel sympathetic to the cause. There's a significant cost in terms of the HLA typing as well. So at this point, stem cell transplantation in South Africa in the state sector is very limited. It previously was limited to those who had siblings only as a match, and it's now changed to say, if you can have a local donor, then we will cover the cost of your transplant in the state. Unfortunately, the registry needs to be expanded in terms of its donor base. It was started off by a family whose child had required a transplant, a white family, but at this point, it is not representative of the non-white population of South Africa, and we need to do a lot of work to improve that. So if in this case, AD has got matches on the overseas registries, what happens? If you have medical aid, you can, depending on your plan, access some of those overseas donors, but there are significant costs involved. There's also been discussion about cord stem cell banking, but I haven't seen any progress on this as yet. The other thing that I do need to speak about briefly is the blood, because when we give chemotherapy, we kill not just the cancer cells, we kill any dividing cells. And specifically for leukemias, that means we kill the good cells in the bone marrow as well. This is the current message displayed on the SANBIS website. And what the reality is right now we don't have blood, which means we are limited in terms of how we treat our patients with intensive chemotherapy. So again, usually blood drives are done in schools, in factories, and all of that has been turned on its head with COVID. So SANBIS and the South African Bone Marrow Registry are two key partners when we come to treating leukemias. I'm going to speak just briefly about late effects, because once you survive your cancer, does it end there? We are grateful, we always give thanks, and we tell parents and we continue to pray that our patients stay in remission. But post-remission, there's a new set of problems. And our clinics at this point are not well geared to recognizing this, because we are actually doing a little bit better and we have patients that are surviving. So this involves virtually all systems, and a big part of this also is the treatment-related obesity and metabolic syndrome, the cardiac damage, the cognitive defects, and the psychosocial issues. We always stress that patients and parents need to remain within the system for monitoring. So if you do develop any of these things, like a second malignancy, endocrine abnormalities, you can actually access care timeously. The cost of cancer care is exorbitant. So if you look at, this is the US, not the best country in the world in terms of how they manage their healthcare systems, but it gives you an idea of exactly how much it costs to treat malignancies, right? And in the index hospitalization in that first year period for leukemia, you're looking at massive amounts. But it doesn't end there, because there's the other side of it as well. There's the cost of getting to hospital. There's a cost of not working. There's the cost of food. There's the out-of-hospital or out-of-pocket medical expenses that are not covered by your medical aid. So this cancer journey, I wish it would be one of certainty, but medicine is far from that. It's a science, but it includes a science of uncertainty and the art of probability. And this is where we sometimes find ourselves. We are worried about the patient, but we are not with the patient. We want evidence-based medicine, and we lose holistic medicine. We want patients to make decisions, but we sometimes make the decisions for them. Is there a better way to doing this? Okay, and is there more to medicine? Is there more to this patient with leukemia? So the question is, what's missing and how can it be filled? And the answer to that is very simply to bring in palliative care. Now, the moment we say this is the palliative care team, it's almost as though the devil is in the room sometimes, because patients and parents equate palliative care with their child dying. And this is not what it's about. It's about bringing quality of life. It's about bringing a holistic approach, and it's about bringing support to parents and families. So that is the one thing. The other thing that I just want to touch on briefly is complementary therapies in oncology. And, you know, many patients will do what they think is best for their children, whether it's buying them insure, whether it's looking at cannabis, exploring what they can to make their children better. So in as much as the complementary therapies come in for a lot of criticism, I think people forget what is at the heart of complementary therapy in oncology. And these include love and support, finding ways of making time for that, good nutrition, facilitating movement, managing stress, ensuring your sleep is optimal, both for the parent and the child, because if you don't sleep, your body will not heal. And overall, creating a healing environment amidst very difficult challenges. So palliative care and complementary medicine is not something that we must look away from, because it actually empowers patients and parents. I can't end a talk without discussing the St. Cillian warning signs for cancer, because the reality is 80% of our patients with solid tumors come to us with advanced disease. Okay, St. Cillian signs were meant as warning signs for parents to identify. And this is run by CHOC. It's broadly accepted in South Africa. And this is also because in the developed world, 80% of children with cancer will survive. In the developing world, only 20% will survive. We need to change that. So why do we advocate? Why do we have people like Theo and Carl around us? Because unless someone like you cares a whole lot, nothing is going to get better. It's just not. Okay. When I was preparing for this talk, and I thought to myself, 2020, what's different? Google, this is what came up. Since 2017, the US FDA has approved 53 therapies to treat patients with blood cancers. And the Leukemia Lymphoma Society has helped advance 46 of these treatments. In the 18 years in state, I've just got 2 new drugs, which have been approved decades ago in the US. We are very, very far behind, and we have much to do. So I'm going to end there. Apologies, I've taken a bit more time. This is Childhood Cancer Awareness Month. We need to support our children, our parents who are doing their best. We need to admire the survivors for what they've done. We need to honor those that are no longer with us. And we never, ever need to give up hope. Hope is what keeps us alive. So this is by Pewee. And this is the article which describes the 50 years of ALL. And I just love what he says, because he says it is the audacity of a small group of investigators who confronted a childhood cancer with the goal of cure and not palliation in their mind. I'm going to end there. I hope that this has been informative. Thank you.
Wow. Thank you so much. I think what an absolutely informative talk and discussion. But I think what really strikes me is I often get asked the question, you know, why is it that people are always fundraising for cancer patients? And I think very often there's this presumption that if you're on a medical aid, that it's all covered. I, for one, didn't realize that the access in the state facilities was so poor in terms of access to new therapies. I knew that obviously the more expensive therapies, there's always a massive delay, but I didn't realize just how dire the situation is. And I think it's just given a lot of context as to, you know, the struggle that these families go through and why it is that you see so many people fundraising, you know, why there is such a big lapse and a big unmet need. So I think that's really been an eye-opener for me. And I mean, when you consider that we work in this industry, it's really, I mean, like I feel guilty that I wasn't aware of the, you know, the absolute lack of access in the state services. I wanted to ask you, as a clinician, if you had to look back at the patients that have arrived in your clinic, I think as a parent, the signs and symptoms that you mentioned, we've all seen at some or other stage in our children, being that fatigue, you know, the odd nosebleed, etc., the bone pain, you know, you associate it with growing pains. It's very, very difficult to ascertain at what point do you seek further assistance or do you start worrying about it? As a clinician, what would you say is the one thing that when you see a patient presenting in your room, you immediately say, is it that the patient's exceptionally pale? Is it that enlarged spleen and that enlarged tummy? Is it the lethargy?
I think that's a more challenging one, Kelly. It's often a constellation. So, you know, there's some patients when they come in, it's the pallor, the lymphadenopathy, the hepatosplenomegaly, and the bone pain all together, right? And that's a typical presentation. But we've had parents who have gone with their gut. My child's got a fever, it's not going away. I've had 3 courses of antibiotics. Something is wrong. I can't put my finger on it, and they've had to persist with it. So it just depends at what stage of this cancer the patient presents to you. And therefore, it's difficult to say specifically that, you know, anemia is the clincher or the bruising is the clincher, because it could be a sign of other diseases. So it's really, if you have a child who has previously been well and suddenly now is just tired all the time and is no longer doing his activities, then that tells me something is more deeply wrong.
And when you refer to "and is now," that time frame, is that a relatively sudden time frame? I know it's difficult to categorically state a, you know, blanket statement, but is it 6 weeks? Is it 3 months? Is it a year?
It's definitely not a year. These are acute leukemia. So this is usually the history in most cases would be about 2 to 3 months. And in some cases, we've had very acute histories, 3 weeks, large mediastinal masses with T-cell leukemias. So it's that kind of time frame, 2 to 3 months, sometimes shorter.
Okay, thank you very, very much. I have seen that there are some questions. One came through from Dr. Helen Malherbe, who is an epidemiologist, asking, you referred to the cases indicated in the slide for South Africa, the number of cases. Was that annually? Was that indication annually? It was in one of your earlier slides.
So our total number of total number of malignancies for South Africa is in children is sitting at about 1,200. And about 30% of those would be ALLs, or acute leukemias. Yeah, so that's the kind of number we're sitting at.
Okay, and a question came through from a mom saying that her 4-year-old to genetic testing and that they saw he has a CSF3R mutation, which is exclusively associated with chronic neutrophil leukemia. They've done a bone marrow test and it was fine. How can they monitor him in future? Do you think he should have cancer, according to his mutation in the future? He was born with severe low neutrophils, and that is why they did the genetic testing. And he is currently on the Neupogen injections 3 times a week. So what, from a parent's perspective, should she be monitoring?
Okay, so that would be a much more rare leukemia. Chronic neutrophil is usually chronic myeloid leukemia that we see in children, and another variant is called JMML. So here I'd look for the usual, because this might progress, and she would probably need to do a full blood count. I'm not sure how frequently they're doing it, but possibly every 6 weeks to every 12 weeks. And that would actually see whether the rest of the abnormalities, if there's any changes in the HB, the platelets, the white count. So that would be the first thing. And then the second thing is the doctor might suggest doing a bone marrow every 6 months or once a year to see what is happening in the bone marrow and if there are any changes there as well.
Sure. Those initial images that you showed of that child undergoing, the bone marrow and the bone marrow aspiration, as well as the lumbar puncture, I think they were gut-wrenching for me as a parent, because I can only imagine what it must be like to present at a hospital. Someone mentions the possibility of a cancer, and then you subject your child to such invasive testing. In that scenario, I think a lot of times parents would like to protect their child. What would be your advice in that scenario in terms of communication with the patient? Is it honesty is the best policy? Do you try mitigate it to some extent?
No, I think, and this was a discussion I actually had with the registrars today. And children, if you are dishonest with you, they will never trust you again. So my cardinal rule is do not say to a child, it's not going to hurt, because it is going to hurt. You need to say it's going to hurt. I'm going to try and make it a little bit better, or I'm going to make it quick. And you need to employ the distraction. The pizza's there and there's the reward system. And yes, these are heart-wrenching times, but everything here is about balance. So yes, we get through the bone marrow and there's something great at the end. As a parent, that's what you need to sometimes do to soothe. But on the other hand, remember that for many of these children, a good proportion of them will be cured. And what you don't want, and what we do see, is parents struggle with the balance of discipline and saying no when they're looking at their child and the child is ill and they don't know if this child is going to survive. So what I usually say to them is, look, in the times when they're in hospital, when they're going through their procedures, you need to do what you need to do. You need to be there for your child. You need to comfort. And to a large extent, you do need to give in, okay? But that doesn't mean you don't ever discipline your child and you don't ever say no, because what you will end up then is with a 16-year-old that you're going to find impossible to manage. So there's a time and a place for everything in this. Sometimes one does need to say no, but it depends how you do it as well.
Sure, thanks very much. I think that's also a reminder to all of us rare moms. I think it's always a difficult, balance to find in terms of long-term disease and, trying to raise normal children in an abnormal situation, so to speak. Well, thank you so much. Much appreciated. I hope that you will be staying on the line in case further questions come up. I'm now going to introduce us to our next speaker, who is Trevor Steyn, who is from the CML Association. Trevor's also a patient, and he was diagnosed in 1989, so quite some time ago. And I'm going to let him tell you his story because I don't think I can do it justice. The title of his talk is The Patient's Journey with CML. CML is not a death sentence. So, Trevor, over to you.
Thank you, and good evening, everyone. Thank you, Dr. Yasmin. I just love the way you are so passionate about what you do and about talking about the disease. So I'm going to change tact a little bit, given the time constraints. And I just want to say that, Doctor, you have raised some of the challenges that patients face. Now, I was diagnosed 28th of September, 1989. Now, at that stage, it's just amazing. There were no cell phones and all those luxuries that we have today. So I went to the doctor, who initially thought that I might have an enlarged spleen. So he sent me to Grooteskier Hospital to have further investigation. And I received a telegram a few days later to say, please report to the unit urgently. And when I got there, I was told that you have chronic myeloid leukemia. I had no clue what this was all about. Absolutely no clue. So I was transferred from where the diagnosis was made to the hematology unit. It was just a brand new unit. They were still building the new Grooteskier Hospital at the time. And I was transferred to the hematology unit under Professor Jacobs at the time. And the doctor who saw me said to me, do you understand what this is all about? And I said, no clue. And he said to me, with the current therapies that we have, there's a lifespan of between 6 months and 5 years. And so that's the reality that you face. There is the possibility of a bone marrow transplant, but that depends on whether your siblings would be, a match. And so started the process. I must say, in the 2 hours that I remained in the unit, whilst I was busy trying to understand what was going on, I was, in essence, devastated. I had no clue what to do. What was worse was that I had, at that point, a daughter who was only a few months old, and we were only married 2 years or something like that. And I needed to call my wife and let her know that she needed to come to the hospital. We were lucky at the time she arrived, because we were, as I said, I can't even begin to describe what devastation means at that point. As I walked past a lady who is late now, and she was the hospital chaplain for the Anglican Church. And she knew who I was and came to me and said, what's going on? And I explained to her. She took us in her office and spent some time with us. And that helped us to go home. And I must tell you that the journey from there on was a really difficult one. First of all, there was stigma attached to it. And I am surprised and shocked that even to this day, there is stigma attached to a disease like cancer. And none of my siblings, they were all tested, and none of them were a match. So I had to make peace with the fact that I had a maximum of 5 years to live. I needed to work out, how am I going to do all of this? I always tell the story that I found extremely funny, because the same doctor who told me that I was going to, what the time frame of this therapy was for us to live, He then said to me, before you start treatment, we need to check whether you would like to have more children, because the therapy that you're going to have might affect, you know, your ability to have children. I said, are you crazy? You think I'm going to settle this lady with another child when I'm busy dying? And we just, you know, at that point I started my treatment on hydroxyurea, and that was the treatment, you know, and it was quite difficult because we needed to get the white cells under control. And I went through that whole process. Then Prof called me in and said that there was a trial happening. The trial was full, but one of the patients who was supposed to be on the trial had died, and there was now an extra place in whether I would like to take it. This was what was then called alpha interferon B, and it was intravenously administered, and I had to do it myself. I stayed on this for something like 18 years, and every single day without fail, I would take the injections. And then, of course, I was offered to go on to a further trial, which was with imatinib. Now, on the alpha interferon, every 6 months we used to do a bone marrow biopsy. And I can assure you, I've had so many of them that I think today I'm beginning to feel the effects of them on my back. But then we ended up with imatinib. Within 18 months of taking imatinib, I was cytogenetics negative. And, you know, I've just had my PCR taken recently, and I still have a very deep molecular response. Now, over these years, a couple things happened that I think is critical for the management of this disease. One of the things is that I believe a critical part of the management of the disease is that the patient need to be in a support system. Support is everything. My journey was a very, very lonely journey. I, luckily for me, had my wife and children. We had another child, and we adopted another child. So we're very happy, lucky family. But there comes a time that you're afraid to speak to people, because it's almost like you're afraid they're going to treat you like a sick person. And you know, you're not allowed to live the life of a full human being because you are sick. And that, I think, is something that needs to be addressed. It was only when my wife, now probably about 11 years ago, my wife was diagnosed with breast cancer and had surgery, mastectomy and reconstruction surgery and so on. And when she came from hospital, the first thing she did was to set up a group, a care group, and they started working together. And I realized then that I have walked this journey. It was important for me to continue to support. And so I started to work on support and met up with people from the Max Foundation and others. And we managed to start our support group. And today I think it's critical that people understand that the patient is critical in the process, and the voice of the patient is critical. But we need to build an organization of carers, people who will care without judging. And so that is what we try to do through CMLSA. I'm telling you this because I think that when many of the people who are newly diagnosed contact us and they talk to us. They are scared. They still believe it is a death sentence. And our view is that the therapies and the medicine for this disease have developed in leaps and bounds over the last 30 years that I've been a patient. We are deeply, deeply thankful for the research and the work that organizations such as Novartis and others do to help give us the opportunity to be where we are. And so I have seen many patients around the world now who are in what is called TFR, treatment-free remission. What a wonderful thing. And so it is important that we help patients who are especially newly diagnosed understand that it is not a death sentence. They need to, however, as we have to do it, is to make sure that you follow the doctor's prescriptions carefully and without fail. If you have to take medication every single day, make sure you take your medication. That is critical. We have, you know, in my case, I have had to take medication, as I still do. I now take it every day at the same time and so on. But it is critical not to skip, because I have seen patients. I mean, we have lost one of our patient leaders in Kenya recently, and he told me before he started getting sick that they did not get the medication. He needed to lobby government for them to be able to get the free medication which was given to them, but they could not get it because of political interference. And so, and the guy died because he did not take his medication. So to say to people, do not see, you know, when you are first diagnosed that it is a death sentence, because that can destroy your spirit, your hope, and affect your quality of life as you go forward. I thought it was important, given, you know, there's a unpacking that Dr. Yasmin has done, to just raise some of these challenges that I have faced and make sure that as a community we work together to help ease that kind of pain that has nothing to do with the disease directly, but it is painful. And that's kind of what I'd like to put on the table. Thank you.
Thank you very, very much, Trevor, for sharing your story. What I'm going to do in the interest of time, I'm going to move over to our last speaker, and then we can take questions at the end, if that's okay. Our last speaker of the evening is Cole Cameron, who's the CEO of Igazi Foundation. Cole was a founding member of the NPO Artists Against AIDS in 1992, and although coming from an arts background, he has always keenly associated himself with health and education issues. And the title of Cole's talk is Blood Cancers During the COVID Pandemic. So Cole, if I can hand over to you. Cole, I'm just checking that you're still there. I do see that you are online. I am trying to unmute you.
Here we go. Can you hear me now?
Yes, perfectly. Thank you.
Okay. Hello, everybody. I'm going to speak to you tonight about blood cancers during this unprecedented time, during the COVID pandemic, which has made things even more challenging than they have been previously. Although things have gotten better in the past couple of years with treatment of cancers, we've taken a step back, and I'm going to take you through a couple of patient experiences and challenges that we've seen in the past couple of months. New challenges. Obviously, some of these are very obvious. Things like medication shortages. There was already supply chain management issues. Kelly, you would know about that. This has been complicated by lockdown, courier services not being available. So there's been a problem. Shortages of ICU beds. Obviously, the ICU beds have been turned around, have been reconfigured for COVID-19, and this has certainly impacted on some patient outcomes, especially for patients who needed to have chemo, maybe chemo in a bed, in an ICU bed, in final treatment. So that has been problematic. Travel restrictions across provincial boundaries for treatment. In the Eastern Cape and other rural provinces in South Africa that are large, patients come from very far afield, and sometimes they cross provincial boundaries. So this has been a problem as well. Treatment centers are few and far between, and so that has been a problem. Lack of finance. Now this, of course, I think it came up earlier. Dr. Goga mentioned about the cost of cancer treatment. With people losing their jobs and everything, co-payments and all that, they in private, some of them have no longer been able to afford those. And this means that it's added extra burden to the state system. And delaying time-sensitive treatment. Cancer is time-sensitive treatment because of the lockdown restrictions and also fear. I mean, in all our private practices, we've had to put patients in order of most urgent to least urgent. And unfortunately, we've just had to work within the restrictions and not having a lot of patients in and around each other at the time, because they are very high risk according to the World Health Organization. And so we've had to sometimes delay treatment, also not optimal. And then fear, people are not coming for appointments because they are fearful of COVID. The early detection that the labs have been doing have been redirecting technicians to blood test diagnoses. So our early detection of cancers is somewhat down. The cancers are still there. They've by no means gone away, and we're starting to get the numbers in again. But initially, because this national emergency, lab technicians were focusing very closely on the COVID tests. Patient and family distress at social distancing. I'm sure you'll all agree, and a lot of the doctors say that cancer doesn't just affect patients, it affects families. And patients with the best outcomes usually have good support networks or good family networks. And with social distancing and that is made very, very difficult for patients to get the support and for supporters to feel comfortable knowing that their loved ones are in a remote ward and they can't get to see them. Now, those were some stories that were told me and some that I put together through observations. But what about old problems exacerbated? Transport problems. In rural provinces, always a problem. Patients come far afield, taxis, public transport, these were all scaled down. Ambulance services, scaled down. And accommodation. Again, cross-border, tourist industry. Sometimes we've had to put patients and their supporters in private houses, not supposed to do it, but we've had to do it because they've come far afield for treatment, and we're one of the very few centers that can do it, certainly in our province. A lot of our state oncology health professionals were redeployed into the COVID positive wards. This sometimes impacted on our patients. Fortunately, in hematology, we were kind of spared a wee bit, although our doctors still had to do their rounds on the COVID wards, but that also put patients at risk. Blood supplies. I think you mentioned this earlier, Dr. Goga, that we have effectively a blood emergency. Just today, I went on Facebook asking, please, for blood donations. We really have a problem, and certainly in hematology, we use an awful lot of blood and we're desperate for blood. That has gone down during COVID because the people who would go to the shopping centers and malls and regularly give blood have not. They've stayed at home. They've obeyed the rules. So blood supplies have gone further down. They were never great, but now they're really critical. And with that, stem cell donations have gone down. Lack of platelets, I think you mentioned that. So here we are in the midst of a pandemic. What have we learned? Going into the next phase, we know our system was not prepared to deal with a pandemic, and certainly our cancer centers were overwhelmed during this period. Private medicine was somewhat better able to adapt than state. And now these are some of the things that were told me by patients. So rather than make it sound very political, I will pass these on as they were said to me. COVID exposed a lot of rot in our health system. NGOs with less resources were able to redirect their infrastructure to assist patients. And they did this more effectively than existing bureaucratic structures. I'll leave you with one final thing that was said to me. Corruption or COVID? Which is going to be more deadly in South Africa?
Yeah, sure, Cole, some pertinent thoughts. I mean, listening to Trevor describing his journey 30 years ago and you describing the patient's journey for someone that may have or should have, been diagnosed within this COVID time, I mean, so much has changed, yet so much remains the same. And it is quite a startling reminder, really, of just, I think how often out of control a lot of, it really, access to treatment is, for more often than not, largely being at the right place at the right time. And the impact of being at the wrong place at the wrong time, what the impact is on someone's health. I know that we've seen a massive decrease in screening numbers as well in the rare disease space. And it leaves you wondering whether, there's going to be a third wave of this pandemic. The first wave was COVID. The second wave is ultimately going to be economic crisis. Will the third wave be what would have been preventable deaths that are no longer preventable because we took 6 months out of healthcare? And I mean, really quite a scary thought. So I think for any parents or prospective patients that might be listening, if you are, concerned about your health, picking up symptoms, worried, absolutely don't delay seeking services. Go get the help that you might need and go get checked out and get screened, because waiting simply isn't an option. And the unfortunate reality is that the impact of COVID is going to be with us for a long time from a services perspective. And there is ultimately going to be a backlog on a lot of services. And you want to definitely have your foot in the door. If there's one thing that I've realized, we cannot afford, as South Africans with such a fragile healthcare system, to take time off healthcare. So I think that's, just very, very interesting. I see that there's a comment that has come through from Dr. Goga saying that Discovery CEO was on SAFM this evening and that the cancer diagnosis has significantly decreased, as well as follow-ups and screening.
Yep.
So they are starting to, they are, even from a funding perspective, starting to see that coming through. And, you know, my question, and I suppose anybody who works with Cole and I on a daily basis will know I've been pleading this from March, is what is going to be the cost of restabilizing these patients now that we've missed the prime opportunity to treat them because they've now been diagnosed that much later. So if you had a patient that would have been in stage 1 or stage 2 that's now being identified in advanced stage 3, the costs and the treatment costs are that much higher. The impact of the disease has, you know, it's a lot further in terms of manifestation and physiology, etc. And yeah, it really just is, it's very concerning. I'm grateful that we've had the opportunity to discuss these difficult issues this evening. And I really just want to reiterate to anyone out there, if you're needing advice or you're seeking assistance and you're not getting it, reach out to the NGOs in your area. Chances are that they will be able to direct you quicker than not waiting. That simply shouldn't be an option at the moment. To all of our speakers who have joined us this evening, thank you very, very much. We will be making this available. It has been shared on Facebook, and it will be on our YouTube channel as well from tomorrow. So if you're wanting to revisit some of the discussions in this, or you're wanting to share it with somebody else, or you think that there's a family member out there, etc., who might benefit from having to listen to this talk, it will be made available. So yeah, just a big, massive thank you to everyone who's joined and listened in this evening. A big thank you to all of our speakers for once again taking the time. I know that our healthcare workers and everybody working in healthcare at the moment are completely restrained and we are zoomed out, so to speak. But we really, really appreciate the opportunity to have had these important discussions this evening. And obviously in closing Childhood Cancer and Blood Cancer Awareness Month, I think at least we've gone out with a bang. And if nothing else, we would have created some awareness tonight, and hopefully we would have urged patients that are possibly impacted to go and seek the necessary help sooner rather than later. So just a massive thank you once again. And we do hope you guys have a great evening further. Thank you so much for joining us.
Thank you.